Hi everyone, it's an honor to be here. I do not have any financial interest or conflict to disclose. So, these are the 5 papers I am going to discuss today, and background of these papers has no relationship with the content of these papers. I put them in these slides just to show as a symbol of landmark and also to help you make a plan on your next vacation. These papers we selected with 2 criteria. First of all, we selected the papers that is non-industry sponsored, and second is papers we looked at the papers that has substantial impact on our life of a pain physician. As a pain physician, we do epidural steroid injections, we deal with the opioid, and our practice focus on the spinal cord stimulation and facet denervation. Any publications, papers that cover these topics and also we think that has a long-term impact on the field are discussed in this, are selected for the discussion. So first paper is about safeguards to prevent neurological complications after epidural steroid injections. This was published in Anesthesiology in 2015. The first paper, author of this paper is Dr. Rathmel, who is well known to the field for his atlas. He published the first atlas on pain procedures. So these papers about safe use of epidural steroid injections. As you appreciate that the complications from the epidural steroid injection is very rare, but when it happens, it can be catastrophic, including permanent disability and death. So during the early, some of the case report of the epidural complications from the epidural steroid injections published in late 2000, and FDA working group reviewed existing scientific evidence and they make a consensus clinical considerations. This paper basically described these clinical considerations. So I'm not going to talk about all these considerations they mentioned for the sake of time. So the task book group found that most of the complications from the epidural steroid injections comes from cervical or lumbar transforaminal injections. They recommended that these injections should be performed by injecting contrast medium under live fluoroscopy or digital subtraction imaging. They recommend that digital subtraction imaging is superior than live fluoroscopy. And here use as example, you see that in live fluoroscopy guidance procedure done in the A and B and did not show intraarterial spread, but when they did digital subtraction imaging, they found that intraarterial spread in both live fluoroscopy and digital subtraction imaging. Another clinical considerations they mentioned is about cervical epidural steroid injections, because they found that most of the complications come from cervical epidural steroid injection. They recommended that to perform these injections at the C7 to T1 level, which is the widest among all the cervical levels. And also above the C6 level, there is a gap in the ligamentum flavum. So they recommended not to perform any cervical epidural steroid injection above the C6, and to review the pre-procedural imaging and not to inject any particulate steroid in the cervical or lumbar transforaminal injections. Although the paraplegia or paraparesis during with non-particulate steroid is transient, but paraplegia from the particulate steroid is permanent. The next paper is about randomized control trial on epidural glucocorticoid injections for spinal stenosis. And this is published in New England Journal of Medicine. This is a double-blind trial, but not placebo-controlled. Here both groups got treatment group, they got either lidocaine or lidocaine plus glucocorticoid. And at 3 weeks and 6 weeks, these patients are reviewed for their RMDQ score and pain score, it's functionality score and pain score. They screened 2,224 patients, and their inclusion criteria include more than 50 years, stenosis confirmed by the MRI or CT scan, pain score at least 4 or 7 out of 24 in RM Ronald Morris Disability Questionnaire. With this, after screening 2,224 patients, they allocated either lidocaine or lidocaine plus glucocorticoid in the 200 patients. And these patients, they follow up at 3 weeks and 6 weeks. They did not find any difference, which is the primary outcome of the study, at 6 weeks after the epidural steroid injection. But at 3 weeks, there is difference in both functionality score and pain score. And although the study was not designed to find difference between interlaminar and transforaminal approach, they found that interlaminar approach is more efficacious than transforaminal at 3 weeks follow-up. And here you see, compared to the baseline at 3 weeks, there a significant improvement in the RMDQ score and also in the VAS score. But for transforaminal injections, there is no difference. So bottom line take-home message from this study is epidural steroid injection in lumbar spinal stenosis is only provides short-term benefit. The third paper is about old debate whether or not vertebral compression fracture is helpful for patients with painful osteoporotic fracture. As you remember that there is two well-designed study published in late 2000, and one of the paper published in New England Journal of Medicine from the same topic, and they had a sham control surgery and vertebroplasty surgery, and they could not find any difference in the outcome. Then in 2010, a study published in study conducted in Belgium and Netherlands, and there is vertebroplasty versus conservative therapy. They noted significant differences. Another study published in 2016 and it was done in Australia also showed significant difference between the sham control and vertebroplasty procedure. In this context, the authors wanted to do another study, so improve inclusion exclusion criteria and increase sample size. So there's inclusion criteria include very focal tenderness at the level of the vertebral compression fracture, and VS score more than at least more than 4. There is a more than 50% body height and differences, and focal tenderness on MRI T2 image. They recruited 180 patients, and 91 of these patients underwent vertebroplasty procedure, and 89 patients had sham interventions. And baseline pain score was 7.7 to 7.9 in both groups. After 1 month, in both groups, 3.3 to 3.7 sham intervention. There is no statistically significant difference between these groups. So they concluded that vertebroplasty does not help for painful acute osteoporotic compression fracture. And here is the no difference in the VS score and no difference in the proportion of the patient who got significant pain relief. But you may criticize this paper because there is no functionality assessment in this study. The second paper is about, actually this is third paper, is about association between spinal cord stimulator implantation with persistent opioid use in patients with post-laminectomy pain syndrome. And this is published in JAMA. Journal of American, this is published in JAMA. And in this paper, uh, this paper, the senior author is Dr. Cohen. Dr. Cohen is well known for several um, well designed study and major contribution in the pain field. So in this paper, what Dr. Cohen did, he did a retrospective study, cohort study. He reviewed 552 post-laminectomy patients. Of them, 26th patient had a spinal cord stimulator placed. In these patients, 17 patient, 1,000 he reviewed. They are based on opioid status, which showed there 6,000 patient on long-term opioid therapy. Then after at 3 and 15 months follow-up, out of these 6,000 patients, more than 6,000 patients, he found that 63% patients still on long-term opioid therapy. In the control group, the patient who did not have a spinal cord stimulator placed, he found that 24% patients are based on opioid. Out of these patients, 65.5% are still on long-term opioid therapy. Although they found significant difference between these two groups, but difference is between basically 65.5 versus 63.9. And in the patients who are not on long-term opioid therapy, that means opioid naive, among these groups, they found that 4.6% patient on opioid therapy, in compared to the 4% patient on opioid therapy who had spinal cord dorsal column stimulation. So although these difference is statistically significant, we do not know they are clinically meaningful. And the last paper is about CDC guideline on opioid use, which this paper came out in 2016, but it is the highest cited paper on the pain medicine in the last 20 years. So opioid use in the United States started in 2015. I'm sorry, in 1850, primarily for the treatment of the soldiers. Within 150 years, United States became the major consumer of the opioids, considering compared to any countries in the world. 99% of the hydrocodone and 85% of the oxycodone produced in the world are consumed in the United States, which is a population of less than 5% of the world population, who has less than 5% of the world population. And because of this increased opioid use, opioid related death also exponentially increased from 2000 to 2015 by 300%. If you look at the individual opioids, methadone and semisynthetic had 300% increase in the opioid related death. Heroin came late in the game, and it in 2010, and within 5 years, heroin related death increased by 600%. Now, if you look at your spam folder, you always see there's some emails asking you buy fentanyl from the online pharmacy, and it is significantly, it was became very available in 2013. Within just 2 years, fentanyl related death increased by 1000%. Then several celebrities, including the rapper Prince, also died from fentanyl overdose. Another interesting thing CDC reviewed is opioid related death also depend on daily dose of the opioid. When MME is between 20 to less than 50, it is and MME also depends on the daily opioid use, and is gradually increased when MME also increased. So this why this guideline came out in 2016, and number one guideline is for non-cancer pain, start with the non-opioid pharmacologic therapy. And critics of this guideline say that what are the non-opioid pharmacologic therapy? We have only Tylenol and ibuprofen. Patients come to a specialist after waiting like 2-3 months just to know that they can take over-the-counter drugs. And another thing is, as a result of the limitation of the non-opioid therapy, there is increased use of the adjuvant. Adjuvant means the medications that are real, not real pain analgesics, but we upgraded them as analgesic because of the lack of opioid, non-opioid pharmacologic therapy such as gabapentin and muscle relaxer, which are not opioid and which has significant side effect. But supporters of these recommendations say that this is the way whole world is treating pain. Why our country should be different? And other guideline is establish treatment goals, start with the immediate release opioids, and do not prescribe more than 90 mme. And another, this number 5 is interesting. This they recommended that for acute pain such as surgery, not to prescribe more than 3 days. I vividly remember that when I came to this country 20 years ago, I had a wisdom teeth removal and I was given 30 tablets of Norco. I needed only half a tablet and rest of the medication I never used. I don't think they will prescribe 30 tablets of Norco anymore. And I would consider this as a success of this guideline. So, and then other guideline is evaluate benefits and harms of the continued therapy. Every 3 months, give naloxone, review the PMP, perform urine drug screen periodically, and avoid prescribing both pain medication and benzodiazepine concurrently whenever possible. And clinicians should offer or arrange buprenorphine or methadone in combination when patient has a opioid use disorder. Finally, this is my final slide. I have a small request. If you think our presentation is beneficial, please rate our presentation using this app. And if you think it is not helpful, don't worry about it.